Hej allihopa! Välkomna till det här webbinariet som Posithiva Gruppen anordnar med anledning av internationella kvinnodagen. Som ni troligen vet så kommer det här webbinariet handla om screening för könsbaserat våld inom hivvården. Jag heter Anna Martinez Hoffart och jag jobbar på Posithiva Gruppen. Och innan vi drar igång så vill jag bara informera om att vår tilltänkta moderator har blivit sjuk. Så det är jag som ska lotsa er igenom det här som vi har framför oss den kommande timmen. Lite bakgrund först till varför vi valt att rikta fokus på just könsbaserat våld idag. Förra året så släppte Folkhälsomyndigheten resultaten av en enkätundersökning bland personer som lever med hiv i Sverige. Och där framgick att 1 av 5 deltagare hade varit utsatta för våld i nära relation någon gång i livet och kvinnor uppgav det i större utsträckning än män. I samband med internationella kvinnodagen för 2 år sedan så släppte dessutom Folkhälsomyndigheten en rapport om SRHR för kvinnor som lever med hiv. Och i den rapporten så skrev myndigheten bland annat att det finns behov av att kartlägga och utforska våld bland kvinnor som lever med hiv i Sverige. På global nivå så konstaterar även aktörer såsom WHO att personer som lever med hiv upplever könsbaserat våld i hög utsträckning och att våldet påverkar personens rättigheter och välmående negativt. Och WHO konstaterar även att könsbaserat våld måste stoppas som ett led i att stoppa den globala hiv-epidemin. Så vilken roll kan då hivvården spela i att upptäcka och förebygga våld mot kvinnor som lever med hiv? Det är egentligen utgångsfrågan för det här webbinariet. Och först idag så ska vi få en presentation av Christina Laurenzi som är seniorforskare i psykologi och som forskat på screening för könsbaserat våld inom hivvården med fokus på södra Afrika. Och efter det så kommer vi ha ett modererat samtal mellan Christina och Tina Carlander som är forskare, överläkare och registerhållare för InfCareHIV här i Sverige. Och efter det modererade samtalet så kommer vi öppna för frågor från er som lyssnar. Webbinariet kommer hållas på engelska, men vi har med oss en tolk som tolkar till svenska. Och för att aktivera simultantolkning till svenska då behöver man trycka på knappen som den kan heta tolkning eller interpretation, ser ut som en liten jordglob. Och den hittar du i menyraden då i Zoom-fönstret. Och det går bra att skicka in frågor genom Q&A-funktionen under hela webbinariet. Och då kommer vi lyfta de frågorna på frågestunden. Jag ser att vi har fått en fråga här redan om det blir på svenska eller engelska. Och då är det på svenska nu och så kommer jag strax switcha till engelska. Och den som behöver översättning får det då om man trycker på den här jordgloben. Ja, bara att skicka in frågor genom Q&A-funktionen och så tar vi dem efter samtalet med Tina och Christina. Och under själva frågestunden så går det även bra att ställa frågor muntligt. Och då behöver man trycka på den här raise hand eller räck upp handen kanske det heter på svenska versionen. Och då får man begära ordet. Det kan man göra i själva frågestunden. So now I will switch to English and I would like to welcome Christina Laurenzi, who is a senior researcher at the Institute for Life Course Health Research at Stellenbosch University in South Africa. We learned about Christina's very interesting research during the AIDS Impact Conference that Posithiva Gruppen co-organized in Stockholm last summer. And we are so excited that Christina accepted our invitation to speak at today's webinar. So Christina, we would love for you to start your presentation about your research on the integration of gender-based violence screening in HIV care.
Wonderful. Thank you so much. And thank you again for the invitation to be here today. I'm really honored to be joining on this Women's Day, International Women's Day, and speaking about a project that I've been working on with a really wonderful dynamic team over the last 2 years or so. So today I'll be sharing some lessons from the Screen and Support project in Lusaka, Zambia. As Anna mentioned, I'm Christina Laurenzi and I'm based in South Africa with the Institute for Life Course Health Research that does a lot of diverse work in the region as well as in South Africa on adolescent mental health and well-being, HIV, and supporting families to generate knowledge about what works for improving health outcomes along the life course. I just wanted to take a moment to acknowledge our team, partners and funders. As you can see, we have a lot of people that contributed to this work. So I'm very honored to be here today to represent the work that so many people have spent their time doing. And today I'll be speaking a little bit around the project, the introduction, trying to situate it in the context of the global HIV epidemic and GBV epidemic, thinking a little bit about some of the lessons that came out from the screen and support package that we implemented in Lusaka, and taking some of these learnings forward to think about implications for care in other settings and integration of care. So I think it's an important place to start today as we're thinking about integration of care, HIV, and GBV by remembering that HIV is part of multiple syndemics and can be really sitting alongside and intersecting with multiple social and health-related experiences. I've highlighted a few in this graphic here. So sometimes, violence sits very closely with HIV. HIV also can occur in the context of poverty, and early motherhood is another area that some of our team are really closely looking at, trying to understand how these experiences, both health and social experiences, intersect and play into each other. Many of the same social and gender structures that can worsen HIV and the epidemic of HIV have also served to perpetuate gender-based violence. And so this is just something I want us to keep in mind as we think about what it means to talk about care integration, that we're thinking about this in a health context, but also the underlying social structures and power structures that perpetuate both gender-based violence and HIV. And I wanted to also just zoom in right away to adolescent girls and young women, which is the population that we've been working with through screen and support. So we know that adolescents and young people are at a really pivotal stage of their development. They have diverse needs, and these diverse needs require flexible solutions and tailored solutions. In the region that most of my work is focused, which is Southern Africa, adolescent girls and young women are also bearing a very high burden of both HIV and GBV. So in Sub-Saharan Africa, girls and young women are 3+ times more likely than their male counterparts of the same age to acquire HIV. And this is really the population group in which the epidemic is sitting and is kind of most significant in today's era, of universal treatment. We have a lot of gains that we've made, but we also know that there are significant gaps that remain in supporting the health of young women when it comes to HIV prevention and treatment. And we also see that amongst young women living with HIV, they are experiencing higher rates of GBV. So there's quite a bit of evidence from the region that shows, again, these overlapping and multiplying risks that young women are facing. I just wanted to take a moment to define what we're talking about today as well. So gender-based violence can be defined as violence directed at a person based on that person's gender, or that affects persons of a particular gender disproportionately. And for the context of my talk today, most of our work does refer to violence against women and girls. And this is not to overlook or to diminish the significance of other types of violence that individuals of all gender identities might be experiencing, but also just to reflect on what the experiences are of the young women that we're working with, and really, again, looking at where the burden is of HIV, as well as those experiences. And most of those cluster with adolescent girls and young women. I hope I'm not speaking too fast for you, Gunilla, but I'm going to keep going. So now we're pivoting to think a little bit about integrated approaches to care. This is something that I think is really important. I think we're going to have a really interesting conversation today with Dr. Carlander, thinking around how we can take some of these things forward and these lessons forward, and how can we understand the complexity of these health topics and social topics and think about designing better systems of care that are more responsive, more able to cope. So especially in low and middle income country settings, such as Zambia, such as South Africa, where I'm based, there are limited time, resources, and personnel to really effectively tackle some of the most entrenched health challenges. When you couple this with a high demand for services, there are a lot of blockages, a lot of bottlenecks in the system. So improving patients' experiences and journeys through the healthcare system is one of the key priorities of a lot of public health research. And thinking about integrated approaches might be one way to reduce some of the burden and improve the quality of care at the same time. So these are connections, beyond just health worker-patient interactions. We're also thinking a little bit more broadly, how can integrating approaches to care also weigh into other types of social connections, other types of community-based supports, thinking about where health promotion can be possible. And again, this is the dual purpose of improving health quality and service quality, and also reducing some of that burden. So I'm going to now talk a little bit about the screen and support package. The key question for us in approaching this work, which we've been doing some kind of preparatory work before starting this project in Zambia, was to think about how to help leverage existing resources to respond to a gap in service provision. And so it's not necessarily about introducing a new intervention, coming up with funds and throwing it out of place. It was really about trying to understand what's possible, what are the existing resources and individuals that are doing work in this space, and what are their needs, and what are their capacities to adopt new approaches. So it was very much pragmatic, practical research aimed at leveraging some of these existing programs and taking them forward. The overarching aim of this work was to upskill or enhance the skills of young peer supporters who were embedded in primary healthcare facilities and supervised by facility-based mentors to screen and to respond to GBV amongst young women, adolescent girls living with HIV. And we decided to use this as a kind of testing space. So we had one community that we were working with quite closely, which was based outside of Lusaka, Zambia. And we thought, let's go do a bit of a deep dive in this one community, see what we're learning, see what the process looks like. This was as much about learning the process and tracking the process as it was about the outcome for us. And then we can share some of these findings and think about what does it look like to take these findings to scale. And I wanted to just also have a little bit of a preface to say that peer supporters in this context are young people who are living with HIV, typically between the ages of 18 and 25, and they're really seen as a bridge between the facility and the community. So they're integrating, care and kind of already. And it's really about working in this larger environment, not only going into a health facility space. And this might differ in part to some of the things that we'll be discussing later in this webinar. But for us, thinking about the unique role of these young people to go out into the community, to find young people who were maybe not following or adhering to treatment, to build trusting relationships. That was part of the baseline that we were starting with. So it was also, as I said, about enhancing the system's capacity and thinking about having some structured standard processes, but also being able to have some flexibility within those processes to meet the needs of clients or patients. So I'm going to talk through briefly. There's a lot that I could be covering, but I want to just take a moment to give a little bit of an outline to what I'm speaking about today. The first piece being formative work. So thinking about what the building blocks were that we needed to do this work effectively, understanding context with experts, key stakeholders, and holding some community dialogues or conversations. Thinking about some of the needs that we had at the project preparation stage, which involved co-design and refining tools and the way that we're going to be asking these questions, and then defining the referral pathways that were possible. The actual implementation of the tool, so having peer supporters themselves screen and collect that data from eligible young women and make referrals as needed. And then the dissemination and scaling phase, so really thinking quite in a quite concerted or deliberate way, how are we going to disseminate what we find, look at some of the lessons coming out, and engage with a broader group of peer supporters working at multiple clinics and other types of stakeholders as well, to ensure that some of the lessons that we're learning are able to be shared with people who might benefit. And for us, there were two kind of core areas of key considerations in setting up screening. So these are just a kind of example of some of the things that we were thinking about as we started this project. So when you're asking questions, screening somebody to understand their experiences of violence, in terms of the content, what are the experiences that we can anticipate hearing about? Which experiences of GBV are most common? Which ones overlap in this particular setting? And also, what might be predicting risk? If it's ongoing violence, if it's recent violence, how do we know, or how can we anticipate if there will be repeat violence? And what's the role of understanding longer ago experiences of violence from a year, 4 years, childhood? How do we understand and interpret some of those findings? So it's really trying to understand, what are we asking? What can we expect to hear from young women? Those were some of the questions that we had going in. And then we were also thinking about the delivery. So as I mentioned, we ended up having peer supporters actually playing that role of doing the screening. But in the very beginning, we were even grappling with this base question of who can actually ask about violence. Are they an acceptable kind of health worker to be asking this question, or would that be uncomfortable? How do we ask? Do we ask in a structured way or in a more informal way? How often do we ask? Are you asking every time you see someone? Or are you just asking once and then figuring out what to do from there? So these were a lot of the questions that we had going in. And so to kind of help us figure out the way through some of these questions, we conducted some formative work. And this looked different. As I mentioned, we had some community dialogues. We brought together young women, some of whom were living with HIV, some of whom were survivors of violence, some were married. In Zambia, there's quite a lot of early marriage. So we had women in their early 20s that were married. And we also brought together community stakeholders, so people working as teachers, as pastors, as police officers, healthcare workers as well, peer supporters, social workers, and trying to bring some conversations together, having both deep dive conversations with those individuals, but also bringing people from different backgrounds together in the same space. And again, really trying to understand this context, to understand a base level of acceptability of this approach. And we found that this context setting was really important for us to understand, what can we expect to see, what kinds of things should we be asking about, what's the right approach to ask. And before that screening even happened, it was really helpful. I think we saw a lot of benefits coming from that early stage collaboration and communication that these discussions were able to bring about. We also spoke to some experts working in the violence prevention and violence response space. So researchers as well, people that are doing a lot of work in this field. Although, my colleagues and I have had a lot of focus on HIV, adolescent HIV, and sexual and reproductive health, focusing on violence was a somewhat new area for us. So we were also really conscious of trying to bring in people who would be able to weigh in and structure some of the thinking around this. And then we had some really wonderful and very deep and meaningful conversations. This is a quote from one of the participants shared, just speaking about the social and economic burdens that come from reporting your husband if he's the perpetrator of violence. And so there are a lot of these very deeply rooted, deeply entrenched challenges that were not easy to be solving in this kind of peer supporter-based intervention. And I think for us, this was something that was very important to know from the beginning. As we charted our path. In terms of the project preparation that we did, we were really intentional about involving implementers and responders along the curriculum. So making sure with our peer supporters, who were all young people in their 20s, that they really, we understood their perspectives and their needs and their concerns, but that they were also really aware of what this work might look like, and that we were kind of trying to make sure we wouldn't be putting too much on them. So it was very much an involved process. It wasn't just us saying, here's something that we want you to do, here's the curriculum, but it was very much co-developing that process together. We also looked quite closely at trying to map out different partners to build out our referral networks to make sure that we had an appropriate response. So when you're encouraging peers and when you're giving peers a structured way to ask about violence, what are the next steps, and making sure that we had some of those next steps available before we initiated this process. This was also part of the communications that we did with partners. And then we learned quite a lot from the actual screening itself, the peer-based screening. So this is a photo that we were given consent to use of one of our peer supporters, who was actually a young male, and one of the participants that we were working with. So safe and confidential places for screening were really, really important. We thought in the beginning that this might be happening in a health facility, in the clinic that they go to. Most people, even if they connected at first with peer supporters at that health facility, they were saying, I prefer to do this at my home, or is there another neutral space that we can go to? Because privacy was really a concern. Even at the health facility, there just wasn't enough space to do some of these deep engaged conversations. And obviously, people also had the opportunity to opt out. They could say at the beginning that they weren't interested. They could also say halfway through that questionnaire or that session that they weren't interested in being part. So we were very deliberate about training our peers in ethical conduct of research and informed consent, and ensuring that there were adequate ways for them to connect and to explain the purpose of what we were doing. And I think it was also a valuable learning for us to combine this kind of standardized approach with a more flexible, empathetic response, giving peers the ability to engage off script. So we were very conscious of the fact that we were using peer supporters or asking peer supporters who are health workers, lay health workers, to do what maybe research assistants would normally be doing. And this was a little bit of a testing space for us as well. Were we able to train them and have them adopt some of those research methods of, collecting data that we could use while also retaining their role as a therapeutic person. And I think this worked quite well. It was a little bit of an unconventional decision, but I think it actually worked very well to enable them to have that relationship. And that line between research and practice was a little bit more blurry in this case. So we screened 194 young women living with HIV from the one catchment area around the one clinic that we were working in. And this screening really facilitated a better understanding of experiences of violence. So 4% of the sample, which was around 8 young women, had experienced some recent violence. So, that number wasn't necessarily as large as we had anticipated. However, 33% had experienced violence more than 3 months prior. And for us, this was quite significant. So really showing that there were high levels of child abuse and or previous partner violence amongst our sample of young women who were between the ages of 15 and 24 years of age. And the kinds of violence that are captured here include physical violence, emotional violence, and sexual violence. We also made a conscious effort to have really strong flagging systems or referral systems that initiated some kind of notification. These were tablet-based questionnaires, so peers would receive a notification if someone had hit a certain threshold or kicked off a certain flag that required further attention. And so we found around 24 young women, so around 12%, had at least one flag, and 9 of these young women had multiple flags. So these were commonly looking at issues like mental health that were coming up, adherence challenges, and as we mentioned, also violence. I'm just going to take a moment to dwell here to also say that from these referrals, these flags that would emerge, peers were then opening up a new form in their tablet and really going through a much more structured referrals process. And so we had these very deep kind of case referral or case notes on these particular young women so that we could understand what those challenges were. And this is where some of that off-script engagement happened. So we were really able to learn about what was happening in these young women's lives. And this is where some of the more therapeutic angle came in. And there were referral options that were presented to these young women to think about what types of choices or options they might like if they want to pursue some form of support beyond what the peer supporter is able to provide. So just thinking a little bit about, I'm closing up now, I'm getting to the end of my slides, but thinking a little bit around some of the implications for scaling and how we share or think about how these learnings might translate to a different setting. We know that systems of care can be very valuable for supporting young women who are exposed to violence, but we also found many instances, both through those deep dive case reports, as well as through some of our other formative work, that there were persistent social and economic barriers that were, making reporting or rectifying harmful situations quite challenging. I think this is not new to anyone who's been working in the space of gender-based violence prevention and response. But for us, this was one of the challenges in trying to think about how do we upskill peer supporters to do their work, more effectively, to tackle some of these very, big issues, while at the same time recognizing that there may be limitations to what they're able to accomplish in responding. client-centered approaches to care really guided our response. So we provided options for young women. Peers were making themselves available to have conversations, to say, I'm here if you want to speak. And some of those engagements were themselves very therapeutic for young women. But at the end of the day, we weren't forcing people to make decisions about leaving a relationship or moving to another area. You know, obviously these were decisions that had to be coming from young women themselves. And so I think providing that space was really a valuable perspective that we were able to get from this study. And really having a space for policymakers and decision makers to come together. I think we could have done more of this over the course of the project, but we did have a few junctures at which we had some roundtables. We had a final dissemination workshop in Lusaka in October of last year, and this really enabled us to bring to light some of the things that we were learning and put some of these considerations about young women who are living with HIV and either at risk of or experiencing violence, really put those considerations front and center. And I think for us, this was just a really amazing space to be learning continuously from healthcare workers and peers' experiences. We drafted a workbook that we then delivered to a group of about 25 peer supporters from different clinics. And these materials were really designed to support learning and discussion and sharing of best practices. And I think one of the other things that's come out in our kind of post-project reflections has been what it really means to shift tasks and training to lay healthcare workers or peer workers, especially because peer supporters are young, they're dynamic, they have so much to offer, but they also maybe are still understanding their own boundaries or their own needs. So for us, really thinking about, you know, the clarity of the roles, the clarity of the supervision, and also how to create expectations around extra work, extra pay. That's something that I think we're taking forward with us from this project. So I know I've tried to cover a lot in a short amount of time, but I'm happy to take any of this forward in our conversation. Really looking forward to hearing your reflections on how this might be relevant in the Swedish context as well. Thank you so much.
Thank you so much, Christina, for a very interesting presentation, and thank you for doing this research that we can further discuss. Because I think with this as a backdrop, I would like to dig deeper into the topic and learn more about the Swedish context, as you said, which is now why we're now welcoming Tina Carlander to the conversation. And Tina, as I mentioned in the Swedish introduction, you are a researcher and senior consultant of infectious diseases at the Karolinska University Hospital. And you are also the person in charge of the national quality registry called InfCareHIV here in Sweden. So I wanted to start by asking you, what are your initial thoughts after hearing Christina's presentation? Do you recognize the overall challenge concerning violence against women and girls living with HIV, even in the Swedish context?
Yes, I want to start by thanking Christina for a really nice presentation. And I do recognize a lot of what you've shown, and also actually the numbers, I think, because we haven't done that many surveys in Sweden, but at least the numbers that we have show that at least about between 20 to 36% have or been victims of violence. And I think maybe even that these numbers are a bit low, because I know that in these surveys about 36% of included women were migrants, but we know that about 65% of women living with HIV in Sweden are migrants, and particularly from sub-Saharan Africa. And just from a personal perspective, you know, in the clinic, I would say that it's very common. I would say that at least a history of being the object of violence, either in the country where you grew up or while in the travel to go to Sweden, you know, and here as well when you once you're here. So definitely that it's something that a big problem for globally, I would say.
Then maybe, as you mentioned it, that that many women in the Swedish context are also migrated to Sweden. I mean, they're two quite different contexts, I guess, in Zambia and Sweden, but do you think we can learn something also from the specific context, thinking about that many women living with HIV in Sweden are also from sub-Saharan African countries? Do you think there's something from that specific context that we could like use the research that Christina has presented? Is that useful also in the Swedish context?
Yeah, because I guess the fact that what you can talk about and what is stigmatized, and depending on how you grew up or what context you are in now, is very much relatable, I would say. Yes, definitely.
Christina, do you have any thoughts about that? Like how applicable is it in a second country? Or
yeah, I mean, I think those stories of migration and disruption of your life that you grew up in and moving to a new country, those are the new stories, right, that people take on when they move, and they have new identity shifts and they have new challenges that they're facing. And so those experiences of violence and the difficulty of transitioning to a new culture, you know, I think those are potentially quite separate in some ways. And in other ways, you know, there's a lot of, like Tina said, what we're learning around, you know, the family dynamics that can perpetuate violence, certain social identities, cultural aspects that make it hard to push against violence. So there's a lot of that kind of like deeper level of someone's identity that I think can really shape their experience and how they interact with healthcare services. And so I think there's definitely lessons. I think where some of the more interesting and complicated pieces come in are from that journey to a new country. But I think there's absolutely lessons that we can think across how to be responsive to individuals' needs in these settings.
I would like to focus a bit about also on the screening and how it is done in the Swedish context. So just getting back to the WHO again, they have stated that healthcare providers do play an important role in the early detection of gender-based violence. And in the Swedish national strategy to prevent and combat men's violence against women, it is stated that healthcare providers are important actors in this work. And in 2022, the National Board of Health and Welfare, or Socialstyrelsen in Swedish, they introduced like stricter requirements for social services and healthcare to detect exposure to violence in close relationships among clients and patients. So just to ask, how do you work with the detection of such violence in the Swedish HIV care? Is there some kind of screening in place today?
There is actually, at least at Karolinska where I work, where we see 25% of all people living with HIV in Sweden, so it's the biggest clinic. And there we have, the nurses works really closely with their own patients, so they have a very sort of it's a good continuity by that. And so each year, or at least once a year, they have like a health talk, we call it. So you go through different things, and among the things that the nurses then go through is they get the exact questions: have you been the victim of violence of any kind? And then that is moved forward, of course, if the answer is yes. So and all the nurses have had an online education for this at Uppsala University, and one of the nurses, Christina, she's also attended a longer course, so she's sort of responsible for this. So we have it there. I'm actually not quite sure about the other clinics that follow people with HIV in Sweden. So that's something that I need to take back from this seminar to do, like a checkup. What's the status on all the clinics in Sweden for the screening?
So it's not a national, like it's a routine just at this specific clinic?
Yes.
And has it been in place for a long time, or is it something recent? Or
Actually, that's a good question because I've only worked there since 2021, and at least since then it's been there. But I'm not sure actually which year it started. But I know some of the nurses are online, so maybe they can put in the chat which year it was started.
And do you, Christina, have any like conception? I get, Leah, you've been working mainly in sub-Saharan Africa, but in general, how do you see that this is managed, like in different places? Is it common to have to take this responsibility of trying to identify or detect violence exposure? Do you see that healthcare personnel take this responsibility or not?
Yeah, I think it's a really good question. And I think from what we initially learned through our formative work, it wasn't necessarily something that was streamlined into existing care. So I think you have some really amazing providers that are able to spend time building those relationships. You have lifelong relationships with some of your clients, or, there are nurses I know in South Africa that have been following kids from birth, up through the age of 18, helping them transition into adult care. So you do have these, really amazing examples. I would say that it doesn't seem to be the norm in terms of healthcare providers at the health system interface. And so I think that's where it's been quite exciting for us to see the potential for peer supporters who have a slightly different kind of role, right? They are connected with young people at the time when the nurse or the clinician that sees them at the clinic says, okay, this person's just been diagnosed with HIV, or this person's having a bit of a hard time with their adherence. Are you able to bring them into your support group, or are you able to initiate a relationship with them? And through those kinds of interactions and connections, I think they are able to kind of have that somewhat deeper relationship. And it's about time, it's about affinity and how well you can connect with someone. And I think it was quite an exciting piece of work for us to be involved with, just because we were able to see those possibilities of extending the types of comprehensive care that can be provided. But I definitely think that more needs to be done in the region in general, to think around, especially, not every healthcare worker is going to be able to sit down with every woman who comes in at all ages and say, let's talk about your experience of violence. What's your relationship like right now? But for those women who are particularly at risk, so young women who are living with HIV, sex workers, a broader cross-section of people who are in, displaced or unstable housing, thinking around how can we ensure that we're responsive to some of the enhanced risks that they may be experiencing.
Thank you so much. I think we have already an answer to your comment here, Tina, about how many years. We have asked the question since 5 years back in the clinic, and we have the questions in 9 different languages. Someone is...
Yeah, and of course, if that doesn't cover the languages, we use an interpreter for the comments, of course.
Yeah. Because Christina, you talked about this, like leveraging existing systems and the integration in general, but also like leveraging the resources that you have. And as part of InfCareHIV, people who are living with HIV in Sweden, they are invited to answer a self-reported health questionnaire. Is this what you are using in this conversation, or is that separate?
No, that's separate for now. I mean, the health questionnaire is being updated, so I can't really say how the end result of that will be. But I think for the con about using the health questionnaire for this setting is that we try to use the health questionnaire for online purposes, and I think, to me, it's questionable if this is a safe setting to do that. I think it's better to do it with someone that you trust, and that can also quickly make the help you forward. So I think maybe not include this in the health questionnaire, which is more like self-assessed health. Yeah.
Do you have any thoughts about that, Christina?
Yeah,
would be
sorry.
Yeah.
I agree. And I think, again, there's also the chance that you ask it and someone says no, but they actually are experiencing it. So you don't really know what, someone's ability to respond is in that moment, wherever they're based at the moment, what the other considerations are. Maybe they have children and they're really worried about their children's well-being, and that's factoring into their decisions about who they're speaking to about this ongoing violence in their marriage, for example. So there's a lot of considerations. And I do think, for me, one of the biggest takeaways of this work and, the conversations that we've had has been around those trusting relationships. We see it also with adult community health workers and other types of healthcare workers, that when you have those relationships in place, those facilitate these more difficult conversations. It's very hard. It's very complex to just ask someone that you don't know, tell me about this experience that could be very personal and very difficult.
Yeah. I think it's also important to add, I was just thinking that maybe it's easy to think that once you're in a high income country, you're free to go. But I myself have a lot of conversations with patients that, would like to leave their partner, but they can't afford to. So I think that's, or at least, but then I guess it is possible in Sweden if we give them the guidance of how you could support yourself, even though, but that's a question even here, about having the economy to be independent.
Yeah, I think that's such a good point. Just to respond quickly, I think, some of the things that we were most surprised hearing from young women themselves was that sometimes, the social isolation that might come from leaving, especially a marriage, but even, a relationship, that, women get blamed if they're leaving their marriage. Anything that they do, any small little mistake that they make when they go back home to the home that they were raised in, that gets blown out of proportion. They're to blame. And so there's this really, socially and I suppose culturally significant weight of, you failed in your marriage because you decided to leave. And so even if it's the best thing for her as an individual, there is that collective sense of the balance being disrupted. And those social isolation episodes, or, those pictures that they're painting for us about what this looks like, they were saying, most of the time people just choose to stay rather than go through what is a very isolating, difficult time. And so I think those are just important things for us to also keep in mind. And again, how that changes or doesn't change when you move to a high income country too.
Thank you so much. We have had there's a comment from someone in the audience, also working in HIV care, who is commenting regarding the screening, that if a woman responds that her physical and psychological health or adherence is improved in the hälsoenkäten, I guess that that is the survey, InfCareHIV survey, right? Then we have a recommendation to ask about violence. It's not supposed to be improved, other comment, if it is impaired. And therefore there's a follow-up question after the primary screening. So I guess then more like an indirect.
And then it would be on one-on-one.
Indirectly, So that would
not be the online questionnaire, but a follow-up of the questionnaire.
And that is part of like the national routine then, that if you answer this and that, then this should be asked in the follow-up.
Yes, that there are recommendations that are national of how you should follow up the different questions depending on how they were answered. Yes.
I wanted to ask also about knowledge and like systematic quality work that is being done in HIV care, because as you said, like in your clinic, Tina, you are working with this. But for example, IVO, which is the Swedish Health and Social Care Inspectorate, they have stated that it is necessary for healthcare providers to increase their knowledge of violence and care for victims of violence by developing systematic quality methods. And that they need more knowledge about this. Tina, do you have any like thoughts about the resources available for healthcare clinics and staff to provide this kind of knowledge, or do you have any thoughts about whether knowledge is needed today? You say that we have a national recommendation. Do we have the resources to actually follow them?
Well, I mean, if all the nurses at Karolinska at this clinic could attend an online education, I think that would be possible for all HIV care nurses in Sweden. I don't think that would be different in any other region. And also I want to add that concerning what we know about, I mean, the state of this, or how big is the problem. Actually, Åsa Mellgren at the Gothenburg University is also working in HIV care. She's about to launch a study where this will be measured at a few of the biggest clinics with surveys. So hopefully we'll get some more data and also including more migrants using this study.
I wanted to circle back a bit to what Christina was mentioning about the like his safe space, or where you would open up talking about these experiences, and of course showing from your research you've been using peers to do this kind of conversations and screening. Tina, is that something that has been discussed within HIV care, the use of peers or other people who might have more like safe space opportunities?
Well, I mean, of course, we have a continuous discussion about peers. I think we could expand that overall, I mean, for newly diagnosed and so on. But for this setting, for talking about violence, I haven't heard that that's been discussed, but I really do think that it could be a good addition, because as we talked about, it may be that even if you really trust your nurse, this may still be something that's really difficult to talk about, or to your doctor or your counselor at the clinic. So I think, you know, that would be a good addition. If you just have, of course, the network where you should, you know, move this forward, or like mentors within HIV care, or like for you. Yeah, I do.
Do you want to comment on that, Christina? Like, if did you see any differences between the healthcare staff and the peer approach?
Yeah, I mean, for us, I think it was important that the peers weren't just floating out there on their own and supposed to be dealing with things, right? So that even though they're like really, really knowledgeable, most of them were born with HIV and living, you know, through their childhood, taking medication, coming to terms with their status at different stages, now in their early 20s, you know, really confident, knowledgeable people, very kind people. So they had some of these amazing qualities that you want in healthcare workers anyway. And just curious to think, how can I be doing this differently? But even with all those great attributes and skills, you know, it's not enough necessarily to just have them doing that role. They're not paid, they're not full-time, they're paid a little bit, but they're not paid as a job. It's more of a stipend. So they're not really expected to be showing up to work and, you know, diving in the same way that nurses or doctors might be. So for us, it was really important to have some kind of more structured supervision, clinic-based mentors, someone that they could speak to, and that they had easy access to, not just someone that was there, you know, someone that they actually had a relationship with. So for me, that was quite important to have this kind of two tiers of, or two levels of coordinating this response. And I do think we could have probably done better with really shoring up some of the additional resources, because at the end of the day, and I think we see this with violence disclosure in different settings, you know, you don't always want to relive a very traumatic thing. So if you're speaking to somebody about an episode of violence or a really traumatic recent experience, you know, you're taking that step to share with them the first time. You don't necessarily just want to be referred on to someone else, and then you have to tell them and refer it on to someone else. So that became quite a sacred space, or, you know, really privileged communication, that young women were like, you know, this was actually enough, or like, I'd rather just speak to you next time if I'm feeling something, which was really wonderful in many ways, but also difficult because it meant that our peers were having to continue to play that role. And so I think those are some of the considerations that we need to think about in scaling these kinds of approaches. What are the supports that you have in place? How do you teach peers at, you know, at that really engaged stage to also know that, you know, they have boundaries that they can erect if they need to for their own well-being?
Very true, I think, to consider that. Very important.
I'm looking at the time, and I want to open up the floor for questions from the audience. I I don't see that we have had anyone with, apart from the comments that have already been commented during the talk. I don't see any questions right now, but please do send your questions in the Q&A or in the chat, because we have 10 minutes left. I also have a lot of more questions that I can ask during, but please send your questions now so that I can ask them. Yes, I'll give you some time to send your questions. You spoke briefly, Christina, about different forms of violence, and I'm a bit curious also in the Swedish context, like, I guess building on the question about knowledge, like if that in that online education, for example, is would healthcare staff be equipped to identify different kinds of violence? Is it physical violence, psychological,
Yes.
economic,
Yes,
sexual?
of course. Yeah, of course. Yes.
And then also building about what you were saying, Christina, about like the referral or what happens then after you have disclosed about violence. What would happen in the Swedish context today if it is detected that someone has been exposed to violence? What concretely would happen then?
Yeah, I mean, of course, it's individualized what would happen, but typically it would be the counselor then, because everyone also have their own sort of counselor. So that would be the person that would be sort of be taking over. And you know, they maybe it would be an instant referral to a women's shelter, you know, depending on the severity. But usually it's something that's been going on for a while, maybe, or it's something that's just happened before. So I would say most often it's more a matter of having the support from the counselor and what can I do, and talking about, like I said, the economy, like could I support myself and my children by myself if I left my partner, and those kind of things. And of course we also have the possibility to refer for legal aid, and also we have psychiatrists at the clinic that we can refer to. So I mean, it really depends on, but we have like a program that sort of helps the person who first hears about it, first gets the knowledge. No.
And would you say that there are enough resources in place? Like, is there a limited time, or like if that person would need to meet the curator like a limited amount of time, would that be a problem, or do you see any limits to kind of support?
No, I don't. I think we really managed to take care of these women well. I really do. I think they're prioritized. Yeah.
That's good to hear. Do we have any questions from the audience? No. I would like you, Christina, you talked a bit about what you called flags, and it's maybe not the same kind of flag that I'm going to ask about now, but like I'm just thinking, apart from like verbalizing that you have been exposed to violence, did you identify some ways of like more implicitly talking about violence? Something that healthcare staff could be aware of, asking more questions about violence if something comes up, like I guess something you could call red flags or warning signs that should lead to like further action?
Yeah, definitely. So this was one of the things that I think we were quite interested in, at least from the kind of nerdy side of it. Like, how do we think about the data that we're gathering here, and are we learning things about certain responses that might be associated with violence? So that's why, in part, we didn't just have a few questions that we asked the peer supporters to go through with those young women. We kind of, had a little bit of a building some understanding sociodemographic information. We asked a few questions about schooling, about past experiences of adherence and relationships. And so there were kind of gentler ways to enter into some of those topics. And we also did ask quite a lot around mental health, substance use, and things like that. So we were really looking at some existing research that's out there, but also, trying to understand what's happening in this particular setting that might be predicting, or at least, other things that might be associated with violence. And so in that regard, we really found, and we're still analyzing this data, so I'm hoping that we're going to be able to get it out, written up, and published soon. But we really found that mental health was very strongly associated with violence, which is, again, not necessarily surprising, but it was really coming out strongly in our data that if there was a woman who either had recent experiences of violence, but even prior experiences of violence, they were much more likely to have high symptoms on these mental health items than women with no experiences of violence. And so in a sense, you might make the case that if you do a kind of mental health screening, and similar to what our audience member said about, certain things, saying, are you having challenges? And then that opens the door to a conversation around violence. Those were really predicting those pathways that, okay, this is women with these violence experiences had much more elevated symptoms of mental health. And I think similarly, young women who had early pregnancy and motherhood experiences, so those who are having children before the age of 18, were worse, or more likely, worse off to have experiences of violence compared to those who had children before the age of 24, compared to those who hadn't yet had children. So we really saw that even though in those three groups, the risk was just increasing in terms of the associations with violence. So again, it doesn't mean that we profile people when they walk in the door and we say, oh, this might be what you're experiencing, but it's just a way for, I think, healthcare providers, on all levels, including peer supporters, including nurses, to maybe have an understanding that, these are the things that layer, and that potentially might help us with our response, to understand that these are common experiences. And it can be context specific, but I hear that also it seems like in the Swedish context, there's probably some similar trends as well.
Do you recognize this, Tina?
Yes, absolutely. Can I come with a follow-up? Because I'm really curious about the next step for this research. Where are you heading after this?
Yeah, I think that's a really good question. I think, for part of our aims, we're really focused around the peer supporters. And I think that can be exciting, but also difficult because there still are the patients that need to be supported in the end. So we have the information that's come through the peer supporters around those patients. And so I do think some of the bigger questions about what's associated with this and that, those feed into some larger priorities within the research team that I'm part of, both at Stellenbosch, but also at the University of Cape Town, where they're really speaking to a lot of people regionally, UNICEF, UNFPA, and really trying to think about how can we use data to influence people making higher level decisions about where funding is allocated, what kinds of programs are being funded. So I think that is quite exciting for me to see that there's really some nice pipelines to thinking on a national level. I think, as I mentioned, we were able to engage with some policymakers, but I didn't feel that, there was necessarily a sense of this is the action. So I do think there is some learning that we need to be doing around how do we take these things forward. And then in that immediate setting, you have peer supporters who feel better equipped to have these conversations. And that therapeutic conversation may be enough for some people to say that I'm able to come out and speak about it with someone versus, having a really difficult time and, all the negative things that can follow from that. So for us, having this peer support workbook available online as an open source kind of resource was also something that was important to us. But I think we need to be doing a little bit more thinking about, what are the high level and then the low level, how do we bridge that a little bit more as we take it forward.
And are you doing this kind of assessment in other countries as well, or are you sort of?
Yeah, we haven't actually started doing it in other countries, but there is the organization that we are connected with in Zambia, which is PATA. They work in about 12 other sub-Saharan African countries and all focus on pediatric and adolescent HIV. So they're quite interested in trying to think about how we can take some of this forward, whether it's through that screening. I think ideally we'd like to trim down some of those questions and really just try and think about which items are the ones that are really most impactful. So we don't have to ask, a hour-long or 45-minute long questionnaire. We can kind of trim it down and say, these are the 10 questions that we want to ask. And so we're doing some thinking, I think, with this next phase of data analysis around what could be a useful tool that PATA could, implement with their other partners in other countries to facilitate those conversations as well, and think really about the combination of the soft skills and then the structured questions as well.
Interesting.
I can see that it's already 1 o'clock, and I was going to ask you a question about the take-home message, but I think we'll let Christina's ending commentary stand as the take-home message, because I want to respect our listeners' time also. Thank you so much for being here, both of you. I hope it was meaningful for you, and I hope it was meaningful for people listening. Yeah, I want to thank everyone who's been watching, and a big thanks to Christina and Tina, of course. And I wish you all an inspiring International Women's Day. And yeah, do not hesitate to contact Posithiva Gruppen, you who have been watching, and please do not forget to fill out the short feedback form that will appear in your browser after leaving this meeting. And this meeting has also been recorded, and it will be put up on Posithiva Gruppen's YouTube channel shortly. And please share it with your colleagues and contacts who have not been able to be here today. Yeah, so thank you very much, and have a nice day. Bye.
Thank you.
Thank you.